Good morning. Convening the Committee on Health and Homelessness. Today is November 15th, 2023, Wednesday, 9 a.m. here in conference room 329 of the State Capitol and also via video conference. Welcome to members of the public, members of the committee, and our presenters for today's informational briefing on Hawaii's opioid settlements and initiatives. By way of starting, I do want to acknowledge to the members of the Department of Health, to the members of the UPW families, that we are sending our condolences to Mr. Bautista's family and to all of the members of the Department of Health during this time of tragedy. It is fitting that we are looking at the series of informational topics over the next several weeks and into December, as we will be looking at the very continuum of care that we need to make sure we strengthen as we help and ensure the safety of all of our public safety employees, as well as members of the community. So on that note, members, we're going to start this informational briefing today on the topic of Hawaii's opioid settlement funds that have been coming in, as well as our system that has been building up to address the opioid crisis under the administration of the Department of Health's Alcohol and Drug Abuse Division. I'm going to take some of the presenters out of order, and we have a very good group of presenters who are going to be giving us information and background status, progress reports on the state of opioid settlement funds flowing into Hawaii, as well as the programs that are going to be developing and have developed since 2021 with the opioid settlement monies. We will also have a presenter from Big Island to share with us the progress on Big Island, and then a presenter from Georgetown University Law Center and the O'Neill Institute for National and Global Health Law to give us an overview of best practices developing around the nation concerning these opioid settlement monies, as well as substance abuse treatment programs and policies across the nation. So with that little bit of background, I'm going to take our presenters a little bit out of order and have Mr. Brian Yee of the Deputy Attorney General's, he's the Deputy Attorney General from the Department of the Attorney General's office, to provide us some information about the opioid settlement monies. And if I can turn it over to you, Mr. Yee.
Thank you. Good morning, Chair and members of the committee. I was asked to provide information regarding the various settlement and cases involving opioids. More specifically, I was asked how much money was received and by whom, what are the restrictions on the expenditure of the money, and who has the authority to spend the money. With respect to the first question, I've submitted to you Exhibit A, which sets forth the various settlements, both executed and pending, for the various defendants. Exhibit B also sets forth a summary highlighting certain parts of the injunctive relief obtained from the defendants. This is, of course, a summary, as the actual injunctive relief provisions are very voluminous. I realize that's the injunctive relief is probably not the focus of your committee, but it was important to us to make sure that these wrongdoers do not do it again. I want to make a couple of notes for you on Exhibit A. The first is that, unfortunately, I was not able to separate out the McKesson, Cardinal Health, and Amerisource Bergen amounts in time for the hearing. Also, technically, there are multiple defendants or multiple affiliated companies with each defendant. So although it might say J&J, there will be affiliated companies with Johnson & Johnson that are also included within that same settlement. I also want to note for you the amounts are estimates. We were not provided with specific dollar amounts for the state of Hawaii. So instead, I had to apply the allocation percentage to the total amount of the settlement based upon the qualification tier that I believe Hawaii was able to qualify for. So although I believe this is the correct amount, it's still still an estimate on my part. It was not a number given to me by the administrator of the fund. And you should also be aware, I'm sorry, attorneys always have caveats, I apologize. You should also be aware that for each defendant, there is a separate settlement agreement. So it is not a single settlement agreement that was reached. It was multiple settlement agreements. Many of the terms are very similar. Obviously, it was negotiated, by the states, and so we tried to keep many of the aspects of that settlement similar. And I'm going to try, where I can, to highlight some of the important differences between each of the defendants where important and relevant. First, except for the McKinsey settlement and the outside counsel fees, all of the money goes directly to the Department of Health. So except for McKinsey and the outside counsel fees. With respect to the McKinsey settlement, the Attorney General's office received final payment in 2022. As will be discussed later, the settlement differs from the other settlements. The settlement did not require county approval. The expenditures do not require review by an advisory committee, and 100% of the money must be spent on opioid remediation or prevention. Our office, and the money goes to the Department of the Attorney General rather than to the Department of Health. This was the first settlement, the first monies that came in. We did not have a system set up, so the money went to our office. Our office has approved an annual amount of approximately $419,000 to the Department of Health for the salaries and fringe benefits for a project coordinator, a program specialist 4, and an office assistant 3. The money is to be paid each year, and the agreement is automatically extended unless affirmatively terminated. The purpose was to allow DOH to hire the people necessary to create the program through which the larger amount of money would be spent. I understand that these positions were filled at different times, so they are not all expended in the first year at the full amount. And I don't have a current total for how much money was actually spent so far. But this gives you an idea of how much we have approved that DOH could spend from this money.
I'm sorry, Mr. Yu, just a brief clarification. This is the McKesson money?
This is the, yes.
Okay, the
So this is
$18
the
million.
Oh, McKinsey, I'm sorry. You said McKesson. McKinsey. This is the $2 million that was received by the Attorney General's office. That was received in full. There's no further money that will be paid out, that will be paid to us. With respect to the other settlements in Exhibit A, please note that a number of the settlements are still in the process of being completed, and I think I've noted that in Exhibit A. We now anticipate that it will be done soon. I think just last night I got the last signature on the document I needed to file everything, so we'll be doing that fairly quickly. The bankruptcy court decisions, however, are going to be more complicated, and I just do not have a timetable for the completion of those cases. The money amounts are estimated based upon the final plan that has been submitted to the bankruptcy court for approval. And so although we have the debtor's agreement and our agreement on what the amount should be paid, it still needs the bankruptcy court approval, and there are some objections and other issues that are going on in the case. And so while I certainly hope that is the eventual agreement from the bankruptcy court, I cannot guarantee it. And I do not have a timetable.
Just, again, clarification, that is the Purdue and the Endo bankruptcy court approvals?
Correct.
Okay.
And you will also note that the monies received are also over a period of time, so that we did not receive the full amount in the first year. With respect to the money received, after paying our attorney's fees, I understand that we received approximately $14.6 million in fiscal year 22-23, which is the bulk of the money received so far, although there were additional amounts paid in fiscal year 21-22. Regarding the restrictions on the expenditure of the money, although it can be a little complicated, I'm going to try to simplify this as best I can. I think there are 3 things to remember. 1, there is a use restriction on the money. 2, there is a local share provision. And 3, there is a process requirement. I will not get into any other legal restrictions like procurement and the like as to how the money must be spent. The simplest explanation for the use restriction is that a certain percentage of the money must be spent on opioid treatment, opioid treatment, prevention, and education, as well as other related abatement measures and strategies. For most of the defendants and the clear majority of the money, that percentage is 85%. But the percentage in the McKinsey settlement and the Mallinckrodt court order is 100%. I'm sorry, I didn't indicate, Mallinckrodt was actually a bankruptcy case, but that's completed, so it's not pending. And the exact percentage may be a little higher in some of the other settlements. But the remaining amount, most often 15%, may be spent on treatment, prevention, and education for other substances, or attorney's fees and costs expended to collect this amount. We have paid our attorney's fees, and that is not included within the plus $14.6 million that was received in fiscal year 22-23. So that was done separately. We still have attorney's fees to pay for Teva and Allergan, and that is a matter in process. The local share, let me get back to the local share provision. The local share provision is that the purposes for 15% of the total amount going to DOH is determined by the respective counties, which I'm calling the local share. The amount allocated to each county is determined by a table established in the multi-state settlement. For example, the city and county of Honolulu will determine how approximately 62% of the local share is spent, subject only to the provisions of the multi-state agreement and the state and federal law. Absent a separate agreement between DOH and the county, DOH would be conducting their procurement. The process requirement is that before DOH spends any money, it must be reviewed by an advisory committee, and I'm sure that will be explained further by the Department of Health. An MOU establishing the membership with an equal number of state and county representatives. Subject to the above restrictions, DOH is authorized to spend the vast majority of the opioid settlement money, and with that, I'd be happy to answer any questions.
Okay, members, any questions? I have a number of questions. So we will make available these exhibits you've shared with us, as well as also of public record is the memorandum of agreement that was reached between the state and, I believe, settling defendants Johnson & Johnson, AmerisourceBergen, Cardinal Health, and McKinnon, who all appear to be on this list that you have provided with us. I did want to share with you and ask you about, and I'm going to try to do this, share my screen. Let's see. I need to do this, share screen. So many of the amounts of monies that have been agreed upon are public record, and there's a really robust set of databases out there. From what I could tell, the state of Hawaii has already received, and you weren't able to tell us this, so we can follow up with this afterwards. But to date, the state has received almost close to $20 million. Were you aware of that? And then can you explain this? Because this is what I generated from the public records. And so there is essentially $20 million, more than just the $2 million from the McKinsey settlement that the state has already received. Is that inaccurate?
No, I think that's accurate. I think of that amount, approximately $2.5 million was spent on attorney's fees and costs. But the remaining amount of that should be the amount going to the Department of Health. Okay. That should be separate from the McKinsey settlement. Okay,
so this would be from the J&J, that's the distributor's year 1 payment, year 2, year 3 payment. Is that correct? Okay, and then once the money gets transferred from Attorney General's to Department of Health, you folks no longer play a role in allocations. You leave that to the committee, is that correct?
Close. We do leave it to the committee. The money does not go to the Department of the Attorney General. It gets paid directly from the administrator to the Department of Health. Okay, and then you, just to recap, the McKinsey monies, $419,000 have gone to pay for staff within Department of Health, to your knowledge. We've approved the payment of an annual payment of approximately $419,000, but the actual expenditures I don't have because they still had to hire the people, and my understanding is they hired them at different times, so I'm not sure what their status is on the project coordinator, for example. Okay, so we'll be able to follow up with that later. And then in terms of that staffing from the $2 million, then that's going to cover about 4 years of staffing? Or that's divided by, whatever the number is divided by. Although it is possible that at some point the larger share of money can be used for that purpose as well. So if at some point the Department of Health decides that it wants to use the opioid distributor money for that purpose, they could do that as well. Okay. I'll stop sharing the screen, but I think this is like really important to know when the monies are flowing in. And I acknowledge that your exhibit is very good because this is not, I could not find some of this information in the public record, but to know what amounts of money and if we have balloon payments, which is clearly indicated by this Janssen
2022 payment. A $10 million infusion into the Department of Health is a significant amount and can help us accelerate some of the initiatives. One other question I have, and we will again make this available because it is public record. The MOA for the larger amount, I believe the Purdue plan, which you say is still sort of not fully resolved. I believe this is the Purdue plan. Looking at the exhibits to say what the money can be spent on, while I heard you say that it has to be opioid related, the actual exhibits and activities is a little bit more flexible. And I want to just confirm that because my understanding is that while it is opioid use disorder, it's also any co-occurring substance use disorder or mental health conditions. Is that an accurate reading of what the
Yes.
the settlement agreement says?
So very often what you will find is that someone with an opioid disorder will also have a mental health disorder. So the money can be used to treat these other problems of people with opioid problems. So yes, it should not be read so strictly as to be only that part of their opioid problem, but also the other problems which also contribute obviously to the addiction.
Okay. I think that's really important because I think there can be a tendency to interpret some of these things too restrictively. And from my understanding, as we've traveled, gone to national conferences, all the conversations that I've been in, actually predating this, when I was health chair previously, there has always been a push from the states in conversation with federal government, Medicaid agencies, that when we talk about substance abuse, it's really a broader application of substance abuse and not just limited to opioids, because we understand that the dynamic of it is that there's co-occurring use,
Yes.
co-occurring substance abuse, and there's a combination of things. And so the other thing I would like to say is knowing that our problem is more meth in our communities. If a person has gone to meth because they are no longer able to receive opioids, that covers their kind of treatment as well, again, as a co-occurring substance use disorder or mental health issue in addition to opioid use disorder.
So I think when you get into the specifics, you got to be I just want to be a little careful. There's an entire exhibit, as you know, in the settlement agreements that describe what constitutes opioid prevention, treatment, and education. So for example, needle exchanges are allowed, but I don't believe we need to check whether they are an opioid user with a needle or some other, because that's just not possible. It is certainly possible that someone who's an opioid addict but also uses other drugs, actually it's not just possible, an opioid addict who also uses other drugs can be treated with this money. I guess I'm getting a little hesitant for fear that someone might try to game the system and really use the money for something completely, really unrelated to opioids. So with that caveat understood, yes, you can use it for an opioid addict who also has other substance abuse problems can certainly be, that other substance abuse problem can also be treated with this money.
Okay, thank you. Again, I just really want to make sure that we have the flexibility, and my understanding is that federal guidance coming down in all kinds of other programs where we're treating the same patient in the community does allow for flexibility, and I just want to make sure that our interpretations also allow for that flexibility, while remaining vigilant and with fidelity to the opioid settlement agreements.
Thank you very much, yes.
So it's a balance.
Yes.
I recognize that, it's a balance. I think, any questions for Mr. Yee? Mr. Yee?
Can I just add one other?
Absolutely, go ahead.
Just on that note, there is a clawback provision that if we don't use it correctly, the money is able to be clawed back by the administrator. But the paperwork is all being done by DOH to make sure that doesn't happen.
When you say the administrator, is the clawback by you or by the administrator overseeing the settlement monies in the court?
The administrator, well, technically it could be us, but because in other states the counties are administering. But it's probably the administrator. I highly doubt our office would be looking to claw back money.
Okay. This has been very helpful, and I'm sure we're going to be in constant conversation with you. Mr. Yi, you are welcome to stay here. You're also, if you have to leave, I understand. But the plan is for this hearing to go until about 11. There might be questions and ideas, actually, from our last presenter that can help inform this conversation. So I urge you to stay, but I also understand that you're very busy. So
If I might, maybe I could join on Zoom. Would that be all right?
that would be perfectly fine. So we'll see you on Zoom.
Thank you very much.
Thank you, Mr. Yi. Mr. Valera, you're up. I think this is a really nice segue. So we know that the department has at least close to $20 million. That $419,000 has been used to fund some staff. We know that in 2019, there was a robust group, the Hawaii Opioid Initiative, that was stood up, various working groups. So we really just want to turn it over to you now to provide us with an overview of what is happening under the Alcohol and Drug Abuse Division. So I'll turn it over to you.
Thank you, Chair. Good morning, Chair and members of the committee. Share my screen. Okay, so this is my presentation, and let's see if I can move this thing. There you go. I'm seeing some stuff. All right, so here's the questions that were posed to the Department of Health. I'm going to go through this presentation, which addresses some of that. With respect to the opioid initiative, yes, we intend to try to rebuild it. Somehow COVID has taken an impact on it, and we used to have a support contract for logistics and analytics to do evaluations and help us produce the annual opioid action plan every year. That has suffered. And so that ended somehow in middle of 2021, and so we're trying to see if we can reinvigorate that so that we can get the work groups that are part of the Hawaii Opioid Initiative can get support. Also, one of the earlier successes of that opioid initiative was that they stood up a website, hawaiiopioid.org. We put just a reminder on the website. It's still up. It has a lot of stories, particularly for those in recovery, that really speak to, for those whose lives have been broken by drugs, and to seek, and these are PSAs that we hope to air soon through a separate media campaign during the holidays, so that they can get help, so they know where to turn for help. So we are going to update that website. Another project that we have using settlement funds, I'm getting a little bit ahead of myself, but it all kind of bleeds in. And is that we hope to stand up a separate website, a professionally designed website for the Hawaii, the settlement project. We're looking at what other states are doing, and we're constantly learning. It's, we started this back in early 2022, and the advisory committee started meeting, I believe in December of 2020. So it's been going on for almost a year, and our meetings have been pretty productive. We've been meeting every month, but we hope to stand up a website where the public can interact and see what the planned spending reports are on how we hope to use these funds. Also, we hope to stand up another website which records the impacts, because each of the participating agencies, including Department of Health, will be asked to put an annual impact report together on how the effectiveness of their projects and the people help, that sort of thing. So anyway, I'll just go straight to the presentation, and then we'll go from there, and be glad to to interact with the others and answer any questions. So as far as the advisory committee members, we've heard from the AG regarding the MOA. The current members are Ian Santee, Deputy of EMS of the City and County of Honolulu, Andrew Martin, County Prosecutor at the County of Maui, Mike Miranda of the Office of the Prosecutor in County of Kauai, Tim Hansen, Executive Assistant, County of Hawaii, I believe he's in this call today, Lee Buen Consejo Lum, Interim Dean of the John A. Burns School of Medicine, Ben Kalinsky, he's part of Hawaii Keiki Nurses, a DOE contractor, and watching the naloxone over at the schools. Marion Suji at Department of Health, and as our director's designee, and Gavin Takenaka, Healthcare Administrator, Department of Public Safety. This will be made available, and the link to the MOA is right here down below. We were asked by what rules does the advisory committee operate. We typically take a modified consensus approach, where after the full discussion, we will take either a thumbs up or a thumbs down. Do we need more discussion, or can you live with it? Some sideways or thumbs up. Okay, I can live with this proposal to use settlement funds for this. Project A. But we hope to live to this strong shared commitment to transparency and accountability regarding the use and impact of the funds. I also want to add that the website we hope to stand up should also include some data. So we want to make it as interactive for the public as possible. One of the sample sites that we're looking at is the North Carolina site. They've had a conference on it this year. It's been a national draw, and so they've stood up a website similar to what we would like to stand up. Of course, we're looking at other states, and regarding the opiate settlement positions that we've hired, we've hired 2 out of 3. We're still waiting on the coordinator. We hope to make a selection really soon. We're encouraging them to also continue to study other states, since we're constantly learning as we're moving along with the project. Over the last few months, the settlement committee has met, and we've hammered out some guidelines in terms of what sorts of items to showcase on the website. One is called the Planned Spending Report. These next couple of slides, I don't expect you to read this, but I could send you the PDFs later if you wish. If you wish to know more of the details. But suffice to say for now, there is a settlements planned spending report. So if an agency wishes to do a project, say buy more naloxone, or stand up a website, or do an RFP to expand treatment services, they should give a simple report to present before the advisory group, particularly if they're going to use the state share, and say, okay, tell us about this project, what strategy is it associated with, how much do you need, when is your anticipated start date, roughly, end date, and let's talk about the project, the merits of it, and if it's an RFP, let's discuss it a little bit more, so these planned spending reports we expect to be generated constantly as the group hears from subject matter experts, comes up with more ideas, hears from their community in their respective county, and generates these reports to present, especially if they're going to use the state share portion. And so we expect this to be to pop up at every advisory committee meeting. There's also an annual financial report which is due 90 days after the end of the fiscal year, which gives us basically a status report. How much did you receive? How much did you spend? How much is remaining? again, for accountability purposes. And this is what the North Carolina does. Their state is mainly, most of their funds are given to the counties, whereas in Hawaii, the lion's share goes to the state and 15% to the counties. There's also an annual impact report that I mentioned earlier. It basically asks them to come up with some process and quality outcome measures. How much did you do? How well did you do it? Is anyone better off? Again, we hope to share this on the website, as well as an annual status survey. Given that there is some turnover, even at the agencies over time, contacts change, advisory committees change, members change, so this would be due, once a year. As far as the options and how the funds can be expended, if we tend to go with the traditional channels, if we need to do a competitive procurement, we can do that. It allows for the most competition, is the fairest way to address health disparities. Say, for example, that a certain county wants more residential. Well, we know there's a shortage of residential across the state. Even Oahu could use residential. We could take that idea, that input, and say, okay, maybe we should do another RFP to expand residential opportunities. We can also do non-competitive MOAs with counties and county governments. We've done this with the city and county, where we've transferred $1.3 million of their county share to them for the purposes of training up first responders to, and also purchasing equipment, doing public education, and so forth. So there is a clawback clause in that city MOA, which should serve as a template for the other counties, should they wish to enter into an MOA, when we transfer the county share to them, on regarding monthly reports, as well as some provisos and, just more accountability. And we don't have grant-making authority, unlike the legislature. So we cannot use that option. We're gathering input, looking at input from other states, some of the things that we could do in terms of gathering public input, other than the Hawaii Opioid Initiative, which is more of the professional community. We hope to add a group which includes those with lived experience. We're on a separate project where we hope to change our admin rules to add peer recovery specialists. We hope to do that really soon. We hope to have done that yesterday, but things being what they are, there's just more projects than there is time to do it, and so we hope to get that done really, really soon, so that we can start to train peer specialists to come alongside our clinicians. Regarding gathering public input, we could obviously do RFIs. Other states that have settlement projects, one has done I believe the state of New Jersey, they do a public feedback portal. There's a sample over here, and it's a very interactive survey, and if they want to attach documents, they could. I believe there's an email at the bottom. We have a generic email for our settlement project. New Jersey stands this up twice a year for the public, and then gathers and invites comments. What do you see? What are your ideas, suggestions regarding use of the settlement funds, given the purposes of the fund? They also do some listening sessions. So we're continuing to find ways to gather public input. A bit of financials. We were asked, well, of this 81 million, assuming that's what we get, because it could possibly increase if the AG settles with more manufacturers and distributors over time. We believe is over 19 years. So of this 81 million, this is where it would come from. Of the 81 million we've received, Department of Health has received about 17.8 million to date. The distributions are not a steady stream, so typically the AG gives us some advance notice of when we expect to receive it, and when we receive it, we get it, and then it goes to a general account, and then it comes to the Department of Health account. This slide talks about the state and county share. Based on if we got the 81 million, what it would look like. City and county would receive, the counties together total 15%, and of that 15%, city and county at 62% gets 7.5 million. Hawaii County at 18% gets 2.2 million, so on and so forth. The percentages are stipulated in the MOA. Okay. Good. We were also asked the expenditures to date. So over the last year, we've been ramping up, preparing, hiring staff, meeting with the settlement group to hammer out guidelines on regarding the need to meet the transparency and what we can show the public. As far as the top table shows the 17.4 received to date. Lately, we had a planning session at a hotel near the airport, and we also paid for one of our DOH staff to go to the North Carolina Summit. Payroll and supplies comes about $12,000. Emergent is the contractor for naloxone purchases, and then the city and county MOA that we sent to them is about 1.3 million. So of the funds received, these are the total deposits received, 17.4 million, and it shows, sorry, I'll be blocking my screen here. So it shows this, what the state and county share would be based off 17.4 million. Okay. Then the balances, this is the balance slide. You'll notice that the city and county amount is smaller. Whereas it was 1.6 million here, it's 276,000 here. It basically says that the city and county of Honolulu, for example, stands to receive about 276,000 more in county share. It hasn't been distributed to them yet through an MOA. As far as the relationship between DOH and the counties, while the Hawaii Opioid Initiative helps us to get feedback from the professionals in the community and other agencies, this Settlement Advisory Committee has allowed us to really have regular communication with the counties and get a pulse on them on what their needs are. Past opioid action plans, I believe, have been statewide, but now we can get a county perspective, and they have a place where they can give us. We can communicate with them regularly. That we can help them, assist them as they educate their communities. But then we can also intersect with subject matter experts. And so I think a lot of those experts could come from the Hawaii Opioid Initiative. If we do a good recruitment effort, I think HOI, for it to continue to be successful, you got to attract the right people who know opioid addiction and its many permutations, given that today's clients are presenting themselves with multiple chronic conditions. They use a cocktail of substances, and so we recognize that need to really minister to the total needs of the client, and so we hope to tap subject matter experts from the community, from this White Opioid Initiative, once it's up and running again, and to give the advisory committee the information they need, the data they need, maybe even a subject matter expert on how to do a good evaluation, write a good impact report, how to come up with good process measures, outcome measures. We want to bring subject matter experts and continue that flow, because the drug threats do change over time, and there's always a need for more data and ways on how to respond to the addiction. And my last slide, sorry it took so long. After the city and county MOA, what are some other projects that we hope to do? One is to issue an RFP soon for mobile medication units. We've done several RFIs already, and it's attracted a lot of interest. And so it's a way to address some health disparities, particularly for neighbor islands, where we can have the ability, enable the opioid treatment programs to be able to go to the client where they are. And also, we hope to stand up that professional website for the public that's interactive. I believe that's it for the moment. Yeah.
Thank you, Mr. Valera. Members, any questions? The next presenters will actually illuminate some of the things you've discussed, Mr. Valera, but I do have a question. On the $17 million that the department has already received, have there been any decisions made as to what that $17 million will be used for, or are you folks just sitting on the money?
So we have I believe the last slide shows that the recent projects that we hope to do, the mobile medication units it's going to be it's going to be millions of dollars, and the website maybe about $100,000. So there may be some other. Right, this is besides the city MOA. So we also hope to stand up a media campaign, run some ads through the holiday season, around $50,000.
So while I appreciate that, I mean, we'll have more insights moving forward as you folks produce spending plans and
Yes.
spending reports.
Yes.
Because, a $17 million chunk of change could be used for maybe more urgent matters. In this committee, we have discussed the need for stabilization centers for those who are experiencing drug episodes. I respect that mobile medication units are very important, but when we have this amount of money, and I understand that it's over time, that's the other concern, right? The department has to consider how to expend these monies over time, but this is a chunk of change that has come in. I think how you folks spend it is going to be something that I think we need to have a lot of transparency around. And folks on our side of the table, because we have some of these greater needs, how do we fill those gaps immediately and then plan for the future? Because I don't want to say that all of the things that we're going to need to do is going to be used through these settlement monies. Clearly, it's not. It's only a small amount of money. But I think our future presenters may be able to suggest to us how we can braid and blend funds so that maybe this could be seed money for really important things that we need now. I'll just leave it at that, but I think this conversation is really important. We had a previous offline conversation. Is it your view that these meetings of the Settlement Advisory Committee should be subject to sunshine?
The answer is, I believe it's in HRS 92-2, where if the group is established by a statute or a law or admin rule, then it would be subject to sunshine. But being that this advisory group was established through this MOA, I don't believe it is subject to sunshine.
Okay, I think your interpretation may be right, but I also think that the MOA doesn't limit or impede sunshine. So I do think that as we go forward and look at different policy frameworks, I think in other states, there's far greater transparency. And maybe we need to figure out what the balance is, but I think that is a conversation we need to have as a committee and with the department as we move forward. So I just want to put that on your radar, because I think how we spend money is clearly very important to those of us sitting on this side of the table. And we want to support efforts that are going to make sure that our patients and our residents are being taken care of. How we fund in the future, that could be for other legislatures to determine, but we also want to make sure that urgent needs are addressed quickly. I think on that note, let's turn to Tim Hansen, who is from the County of Hawaii, who is also a member of the advisory committee. Tim is on Zoom. Thank you, Tim, for joining us. I know you have a busy schedule, but can we turn this over to you now for your presentation to the committee?
Absolutely. Greetings and aloha from rainy Hilo, where it's wet but green, and we're thankful. And I'm thankful for this opportunity, Chair and committee members, to be able to speak to you a little bit about some of the activities happening here on Hawaii Island around our efforts to combat opioid. So I'm doing a screen share. Can you see my?
Yes, we can, Mr. Hansen. Thank you.
Yes, great, wonderful. So I am an executive assistant to Mayor Mitch Roth, and he asked me to be part of the opioid advisory committee, which I was quite honored to be part of. And my background is I'm a licensed clinical social worker, and much of my career has been focused on the wellness of community, and that is why Mayor Roth has brought me onto his team. My main focus is around community well-being, which includes mental health crisis response, which I held a summit in August to kind of look at our lacking crisis response here on the island. Also around drug treatment and also conflict resolution and peacemaking activities. When I was invited onto appointed to the advisory committee, we had a strategic planning meeting in June at the airport hotel there in Honolulu. And I was kind of a loud voice because I feel very motivated around this issue. In June, I talked about how here on Hawaii Island, we were experiencing one death every 13 days because of overdose. And I just feel like that's unacceptable, of course. And I don't know what the stats are statewide, but again, just looking here on our island. Today, that number has been updated. We're experiencing one death every 11 days. And so that trend is going in the wrong direction. And so what I'd like to cover with you this morning is some of the work that we're trying to do to address the crisis experiencing here in our community. I want to talk a little bit about the Hawaii Island Fentanyl Task Force. I want to talk about the UH Hilo Masters in Psychology and Counseling program, and also our needed expansion for treatment, and most importantly, a detox center, which is non-existent at this point here on the island. Hawaii Island Fentanyl Task Force began really in response to the overdose death of a 14-year-old girl over on the Kona side in November of 2021. A small group of people came together and approached Mayor Mitch Roth and really said, we've got to do something. And a coalition came together and we formed as the Hawaii Island Fentanyl Task Force.
Mr. Hansen, I just want to let you know, can you advance your slides as you're telling this wonderful, giving us this wonderful information and story about how you folks started?
Okay, they're advancing for me, but not for you. That is interesting. Okay, is that?
We're on the, yes, and one more slide.
Okay. Oh, I'm so sorry. I don't know why it's not going. All right, so you're going to miss all the fun popping in and outs of data that's somehow showing up for me, but not for you. But most importantly, you'll see the information. Sorry about that. So yes, the coalition, the Fentanyl Task Force came together. It involves over 75 members from various organizations and groups from around the island. And we have completed 2 successful island-wide summits. Our summit last spring brought together over 300 people to talk about, learn about fentanyl and the needs here on the island. Our vision is a community that is aware, informed, and empowered to prevent addiction, drug overdose, and other consequences of drug use here on Hawaii Island. We are organized and have 6 specific priority areas, and we have active work groups working in each of these areas. The first being education and prevention. We've done hundreds of presentations in classrooms, in various schools, and other community settings around the island to try to educate people about the realities of the opioid crisis, fentanyl, and all of the risks and downsides of addiction. We've got a work group looking at screening and early interventions, as well as a treatment group. These are the 2 that I'm most active in as we are identifying all of the treatment options here on the island. We do a monthly contact and assessment with each of the treatment providers so that we know how many beds are available, what is their wait list, as well as what is the average length of time as people are waiting to get into treatment. We don't want to see people having to wait weeks or even months when they feel as though they're ready to enter into recovery. And so we're trying to reduce those timeframes. We haven't started to collect that data yet. Our goal is January 1st to start collecting that monthly data. And then once folks have completed treatment, of course, the really, really important aspect of recovery support. And so we have a very active member with lots of folks with lived life experience around addiction and recovery that are part of that work group to make sure that we're doing all that we can to, my PowerPoint just went out.
Mr. Hansen, I'm going to share your screen, so you can keep talking. Go ahead.
Okay. All right. And you've got the presentation?
I have the presentation. Go ahead.
All right. All right. Yeah, so I think I'm back up a couple of more on the Fentanyl Task Force. Slide number 4, please. There we go. Almost. All right. And then we have our harm reductions work group. And one of the things that we're working on is, of course, the distribution of naloxone. And we have distributed hundreds of naloxone kits across the island. We have 5 dispensing machines that we're working at getting available so people can access naloxone. Mayor recently announced that all of our county facilities will have naloxone available. And of course, all of our police, EMS, fire has those. And we're collecting stories of people literally being brought back to life because of the availability of naloxone. We're also having stories of people dying because of not having access. And so we want to try to make sure that those are in the hands of as many people as possible. And then finally, we have a data analysis and evaluation group that's working closely with Hawaii Police Department, drug enforcement, so that we're tracking the amount of drugs coming into our island, how are they coming in, and what our enforcement efforts are in regards to catching those supplies as they come in. The task force has an incredible website, and this is just the link to it. I would encourage everyone to please go on and take a look at that website. Represents all of the work groups and the amazing work that's happening. So we realized even as we began to push treatment and develop more programs, we have a lack of mental health professionals and folks that are trained and want to get in to this field. And so as we looked around, we realized that Hilo, they have the only Master's in Psychology and Counseling program in the state. It was a program that was established in 2005. They've graduated over 20 students, an incredible 90% graduation rate, which is amazing. And they have a distance ed program, so they have students from all across the islands and in fact all across the Pacific. The students complete a practicum training in their home community. But in order for them to expand their cohort, they of course needed more staff and more programming. So currently they admit 20 students a year as part of their cohort, but they're turning, they have applicants of 75 to 100 applicants a year. So what a shame that we've got students that are wanting to move forward in this field. And so we talked with them about the possibility of expanding their program. Next slide, please. Because their current program, involves 60 credits, master's program. It's a wonderful program. It's accredited through 2029. And again, it's the only mental health counseling program in the UH system. And what we really wanted to see was the expansion of that program to include addiction. So the next slide, please. The need for us was just the reality of the amount of overdose deaths and the shortage of mental health substance abuse providers in the state. We were concerned that at the community college, the CSAC program had ended and had moved to Oahu. And also the CSAC program currently as it exists is really for associate degree undergraduate levels. And we wanted to open up a track that was at a master's level program that would train people to be able to work in the field of substance use disorders, but also having the training and experience around other mental health disorders, because the co-occurring realities of many addictions, of course, is well documented. Next slide, please. And so we asked the university, would you be willing to expand your program to include an addiction track? And they said yes. And in fact, they had been trying to do that, but their funding request in 2023 had failed to the legislature to be able to expand their program. And so here at the mayor's office and the fentanyl task force, we came together, approached the opioid settlement advisory committee and Department of Health, ADAD, and said, please help us. We can't wait for another legislative session to approve or not approve the funding for the expansion of this program. We have to build this capacity, not only here on the island, but across the state and across the Pacific region.
Mr. Hanson, I apologize. I need to interrupt. How much was this legislative funding for the UH program?
John can, well, the initial request in 2023, I think, was less than $300,000. And I don't know what their current request is. They do have a funding request in to the 2024 legislative session. It's part of the Board of Regents budget request. My understanding is that, just that it's part of that budget request. I don't know what the figure is at this point. What I do know is that thanks to John, Department of Health, and they were able to commit monies to expand that program immediately. And so the cohort will expand by 50%. They'll be accepting 30 students starting this upcoming summer. They've created 13 new courses and sections. And so it's really exciting. And the commitment is to provide that bridge funding, but hope that legislature is going to provide the funding, put it into the university's budget so that it can be an expansion that's guaranteed as it continues to move forward.
And I just want to emphasize, these are good, high-paying jobs in Hawaii County.
Across the state, absolutely.
Okay, so an investment of $300,000 expands capacity, addresses our workforce shortage, and immediately can produce folks who can help people suffering in our community. That's the point.
Exactly. Yep, exactly. So I think the funding ended up being more than that. And again, maybe if John is still there, he could probably clarify what amount of money is being committed to UH to support the expansion of this program. And again, I'm not sure of the exact amount that they've included in the 2024 legislative request. Next slide, please. And so again, the timeline for the expansion of this program in 2023, 24, they've included, they've created the program. They've announced the expansion of this particular concentration. So they've begun recruitment of students already. They've hired or they're in the midst of hiring a program coordinator. And once funding is more secured, they will be hiring 2 faculty, one with the substance abuse disorder specialty focus. And then in year 2, thank you for trying to expand that because it's quite small. I don't know what's happening, I'm sorry. In year 2, new faculty will begin, the concentration will be offered, and then in year 3, the cohort will be there and doing their practicum placement in the community, so already beginning to provide assistance. And the first class of the CSAC concentration will graduate in May of 2026. And again, just so thankful that we were able to get that small amount of funding to get this going. Otherwise, we'd be talking about May of 2027 or 2028. And with the death 11 days, I'm not a mathematician, I'm a social worker, but I do know that it's unacceptable. And so we've got funds, we need to expend them, I feel, as soon as possible for these important programs. And next slide, please. Around that urgency, we've been very challenged here on the island by not having a detox facility. So often the emergency room or the jail ends up being the makeshift detox where somebody ends up going through the realities of their withdrawal. And so Big Island Substance Abuse Council has stepped forward, and we have helped them to locate an old hospital here in Hilo Town, and they are beginning the process of establishing a detox center. Next slide, please. They've committed that in January of 2024, they're going to be doing a soft opening with outpatient services just to get established in this location right downtown. And then once the building renovations are complete and all of the required licensing is in place, they will begin to offer a 3 to 7 day residential detoxification program, providing safe and supportive environment in order to detox from drugs. Can be medically assisted if necessary. But again, will be a 24/7 residential kind of spot. It will serve island-wide. And again, the need is funding to support this program, not only in its original creation, but also in its ongoing operations as they try to serve our community members. So we're not having to send them off to Oahu or to other locations, that we can provide that important supportive services around their withdrawal support and then their recovery efforts right here at home on Hawaii Island. Next slide. That really is the bulk of my presentation. This is my contact information if folks need more information. Again, it's a privilege and honor to serve on Hawaii State Opioid Advisory Committee. I share the chair's concern that, you know, we have millions of dollars that are sitting in that account, and yes, we have to make sure that we're spending it appropriately, but we also need to make sure that we are spending it, that we're moving forward. And I have in my mind just the calendar here on this island, every 11 days we're losing someone, and we have to do all that we can, I think, in order to provide the services that are necessary. I really appreciate your time and open to any questions or comments that anyone might have. Thank you.
Thank you, Mr. Hansen. I'd like you to stay on if you can through the end, but I understand if you need to leave. So please stay on if you can. Members, any questions for Mr. Hansen? We have a question from Representative Amato from the island of Maui.
Excellent, thank you.
How many beds will this detox center have once it's open and fully functional?
I'm sorry, I couldn't hear the question. I'm sorry.
Sorry about that. How many beds will the detox center have once it's fully open?
I believe that their plan is 8. But again, part of that's going to depend on the licensure, and the reality of the facility. But I believe it's going to be 8 people, or 8 beds available. And they have toured the Salvation Army's social detox program on Oahu. It's the model that they're really excited about, as well as using telehealth capabilities at the center once it's set up.
Thank you.
Representative Garcia from Kapolei has a question.
Thank you, Chair. Thank you, Mr. Hansen, for your presentation. I have a question. So it's nice to hear that the program at a UH Hilo is growing strong. Question is, what is the specific name of that bachelor's degree that's offered at UH Hilo?
It's a master's degree in psychology and counseling.
Okay, and the specific focus is with opioid addiction?
So their current focus of their cohort of 20 students each year is around counseling. And the expansion of the program will be a CSAC track for an additional 10 students to be able to graduate specifically with an emphasis in addiction treatment.
Okay, thank you.
Yep. And again, it's open to students statewide and across the Pacific.
Members, any other questions for Mr. Hansen? Mr. Hansen, I have a question on the detox centers, but again, I would like you to stay on, and then I think we might have more questions generated from the next presenter. Immediately on the detox, when you say that there's going to be need for ongoing funding, are you talking about funding for the service provider who will be running the detox facility?
Yes, it's for the staff. I mean, they are looking at, of course, the billing reimbursable options. I think the projection is $1.6 million a year to operate this facility. The owners of the building are being incredibly generous with a lease agreement. So funds for the renovation and get everything up and running, and then the ongoing expense of providing these services.
And then will this set of services be contracted by the county, or will it be contracted by the state?
The nonprofit is Big Island Substance Abuse Council, so the contract will be with them. They, certainly they will be seeking funds wherever they're available, and I think as Department of Health, the ADAD, and the opioid settlement funds will hopefully be able to be accessed to support this operation.
Okay, I guess more specifically, what I'm asking is the county going to be involved in contracting with BISAC directly, or will you do it through a state-county partnership?
So Mayor has committed our our county share of the opioid funds, the $478,000. He wants to go specifically to treatment. And we're still in conversation whether to have that contract for those funds come to the county and then contract out, or whether to just direct the allocation of those funds to treatment via the Department of Health through the opioid settlement. So we have options, and we're just trying to figure out what is the best way to move forward in that future funding. And that's around, accountability, report collecting, and that sort of thing.
I think this is a really good point that illustrates how we blend and braid resources, because this is a shared responsibility, and maybe the state, and I don't know, we can have John come up later, or John, if you could join us at the table at the moment. How we contract these services could be something that could be done more efficiently through ADAD, and then it relieves you folks of the burden. Clearly, you folks have the burden of law enforcement assisting with this if this detox center becomes someplace that becomes a drop-off center. So within the ecosystem, there's a lot of shared responsibilities between county and state. So I urge you folks to continue the conversations, but then also to move quickly to design something, because again, like you said, 1 in 11 deaths is not acceptable. Mr. Valera, did you want to comment on any things about how the ongoing contracting might go for the services?
So specifically for the detox, okay, so yes, the Hawaii County Mayor has designated his county share to go to treatment, in this case detox. And so one way we can take that is to we're gonna go out for an RFP for our substance use service array, our full array. It's about 30 different services. Really soon, once we finish, once one of our contractors finishes with a rate study, then we can issue that, have it hit the street, and then make awards around, early next year. But the contract, if we do it that way and apply the county share towards that RFP and award and distribute it to Hawaii County providers that meet the criteria for setting up a detox facility, we can apply it that way through a competitive process. It's just that through this process, though, since we're going to do it for our other 36 providers, it's going to the contracts won't start until October 1st of next year.
Okay, I would urge you, again, we have flexibility here. We have a detox center that's ready to open in January 2024, and you're now telling me they're not going to be able to open until October 2024?
That's the idea that we have right now, but we can continue to talk with the county as to how to try to set it up sooner.
Okay, I think that would be really preferable. I also think, it's not, I think it's not wise to delay some of these things with a bureaucratic process that goes to statewide procurement. And if there is flexibility with these funds that the department is already sitting on, and we just heard that one person dies every 11 days, I mean, there is urgency here. So I think we need to see some action on this, and sooner rather than later.
I'll see what kind of steps we can take with our current contract with this provider.
Okay, I would also suggest, right, again, we have to keep an eye on the urgency and the need to address immediate issues, but we also have to look at sustainability. So we have to hold two disjunctive ideas in our head at the same time. And we can do that, Mr. Verler. I really believe we can do that. So I also think that as you go out for these master contracts, these service providers can draw down on Medicaid funds.
Yes.
And so I guess, and maybe this is a question to both you and to Mr. Hansen, are the service providers understanding the urgency with which they need to make sure that they can bill all forms of insurance, so that sustainability-wise, yes, the state will spend general funds on those who might be uninsured, but certainly insurance companies need to have their feet to the fire and help pay for what is essentially medical treatment. Do you have that ability? Can you assure us that you folks are also ensuring that Medicaid is going to be accessible via these contracts? Mr. Valera first, and then Mr. Hansen.
So, yes, our providers understand the need to bill other sources and, using our funds as a last resort. And so they understand the need to leverage other, possibly other health plans, Medicaid, to pay for these services that are needed out there. Okay. Yes.
Mr. Hansen, what's your read on the ground on Hawaii Island as to the ability of service providers to make sure that they really are hitting all insurance pockets?
I think it's a mixed bag here. I think that some of the larger providers that have the staff and the funds to be able to do all of the billing and to meet all of the various requirements in order to access those funds are doing so. But I think there's also the reality that there are other smaller programs, maybe culturally based programs, INA-based programs, other programs that simply do not have the capacity to be able to manage that sort of billing and or even to meet some of the requirements to be fully certified and then able to access those funds.
Would it be accurate then to say, and I think Mr. Valera and Mr. Hansen, you both could answer this, does the state and maybe the county need to step in with some technical assistance, resource assistance to these service providers to bring them up to speed so that they can then be better partners with us? Is that an accurate ask maybe of the state?
We can see what types of technical assistance we can bring, whether, if we can't do it in-house, then we certainly can tap our federal sources like SAMHSA, who can provide, even CDC, we have a CDC grant also. So CDC also provides technical assistance that we can tap into, seeing how we can resource these rural providers.
Wonderful. And Mr. Hansen, I know that the Big Island has a very, you've spoken about it, but the Going Home Initiative, you folks have a very robust community-based program there. Is the county able to provide some technical assistance as well to some of these service providers?
We can certainly explore that. I don't know that we have the capacity on a county level to do that. We have a very active rural health association, can continue to work with them. I know that we have a counseling service that is really beginning to expand here, and it's because they have staff that are able to take care of all of the billing, the credentialing, and all of that. And then they work with mental health providers that do what they do best and leave all of that billing and everything else to this other entity that they're part of. And I don't know if that's a model that's available in regards to drug treatment possibilities or a role that the state or another entity could play, because it's a different skill set, right? To manage the billing and to talk the insurance language and all of that stuff, as opposed to boots on the ground, saving lives, changing lives.
I think you've hit on something, Mr. Hansen. I think the conversations we have between our service providers, maybe the more experienced ones, with our smaller providers, with agencies like the one that you just talked about that could do billing while the service providers focus on programs, that could be a wonderful partnership, so we should certainly look into that. I think another opportunity we have, and this committee heard from Administrator Judy Moore Peterson about the Section 1115 waiver that is going to go into the federal government to seek contingency management funding for substance use disorders, is going to provide us some time, maybe a 2 to 3 year window, if we are lucky and fortunate enough to get that waiver from the federal government that provides another funding source for different kind of services. But it can also be the prodding that is going to be needed, the ramp up time for service providers to do exactly what they need to do to be able to become certified. So all of this is connected, members and members of the public. And so maybe we all just need to all be marching towards that same goals and then we can achieve some of this. I think this is a really good segue at this point as we start to talk about Medicaid and SAMHSA funding. We have a presenter, Shelley Wiseman, who I believe is on. I want to thank Shelley. She's on the East Coast, joining us, I believe, from, is it Philadelphia or Washington, D.C.?
North Carolina.
I was totally off. Shelley comes to us from the O'Neill Institute for National and Global Health Law. She's a professor, adjunct professor at Georgetown University Law Center. Members, as I said, there is a vast array of resources for us to look into on best practices, and Shelley is part of that group that's looking at this nationwide. So I'm going to turn this over to you, Shelley. Thank you for joining us.
Great, thank you. I'm going to share my screen. Okay. Thank you, Madam Chairwoman, esteemed members of the committee. I'm truly honored to be invited to speak with you today, and I also want to commend all the good work that's being done, just that I've heard about today. This is not an easy issue, and these are not easy changes to make, and I really want to commend the innovation that I've heard. Going to my next slide. So, as mentioned, I am part of the O'Neill Institute for National and Global Health Law. It's a health policy think tank at Georgetown Law Center. And the initiative I work on is focused on translating science and evidence into actionable public policy. I'm a human rights lawyer. I formerly worked in state government and in the governor's office in New York on policy and operations for addiction, mental health, and disabilities. So those are some of the perspectives that I bring to the talk today and to this work. I'm also a person in long-term recovery from a substance use disorder who would not be here speaking to you today without the services and supports that I personally received some years ago. So it's important for me to share that, that we remember, right, that recovery is possible, and that the good work that folks are doing every day in this space really has a tremendous impact on people and families. So in this presentation, I'm going to do three things. First, I'm going to do a quick high-level recap of the litigation, the money, where we're at. I'm not going to belabor that, though, because we heard a lot about it already. Then I'm going to speak about best practices for putting a governance infrastructure in place to ensure that these funds are actually spent on opioid remediation, transparently, with accountability, and in the way that meets the needs of communities. And finally, towards the end of the presentation, I'm going to touch on some frameworks for best practices on what the money might be spent on. So the term opioid litigation, as we know, covers a variety of litigation, mostly by state and local governments, against manufacturers, distributors, and retailers of opioids. Many of these lawsuits have been subject to settlement short of trial. Some have been resolved after a trial. There are a number that have been resolved in settlements. There are still more pending, as we've heard, and we're really looking at upwards of $54 billion across the country, flowing back to states and localities. Another point to know is that not all of this money is coming at once. In one settlement, funding might be distributed over 18 years, for example. In another, it might be 9, and so on. Some of the money is front-loaded towards the beginning of the settlement period, so it's coming at different times over a period of time. And the requirements for how this money must be spent, or any guardrails on the protection of this money, is set forth in a variety of different places, including the language of the individual settlements in state legislation that might also guide how money is spent and who might make decisions about that, and in many cases in agreements between states and counties and cities. And of course, this can vary widely by state, depending on the way the state is organized, what the state and local governments have agreed upon. Hawaii, as we've heard, the allocation is 85 state, 15 local government. In the state I live in, North Carolina, it's the other way around. It's 85% to local government, 15% to the state, and you have everything in between. So that's going to guide how and what decisions are made. And of course, the amount of money varies by state. As again, already discussed, Hawaii shares about 80 million and will potentially be more as more cases are resolved, particularly the ones in bankruptcy right now. So I'm going to go over some governance principles, which are about how government is putting mechanisms in place to ensure that the funding is spent effectively. The need for strong governance is a hard lesson that was learned from the settlement between states and big tobacco, where less than 10% of over $200 billion in funding went towards tobacco-related public health strategies. To prevent this from happening in this case and to maximize settlement dollars, states can consider three things, and I'm going to talk about each in turn. One is that settlement proceeds must be separated from the state general fund. This means, and we'll talk more about it in a moment, that ensuring the dollars from the settlement are truly new money to address substance use disorder, rather than simply replacing the budget that might already exist. Two, governance strategies must be put into place to create and support systems of oversight and accountability. And the third is about implementing a whole person, whole government approach. And of course, sustained political will to address these issues over the entire settlement period is really crucial. Right now, there's a big spotlight on this issue. 10 years from now, 15 years from now, there might be another crisis of the day, and it's important to keep this issue front and center. So on the first governance strategy, the first principle, ensuring that these funds are separated from the state general fund and that they're truly new dollars. This means that, taking an example, if a state generally spends $100 million on substance use disorder per year and gets $50 million in settlement money, it should spend the full $150 million on substance use disorder. What we've seen in some states is that settlement money or money from other revenue that should be dedicated to substance use disorder, like an opioid tax, has replaced some of the funds that the state normally would spend on substance use disorder. So that's what's meant by supplanting existing dollars. For example, a state maybe spent $100 million generally on SUD and got $50 million in the settlement, might only still spend $100 million on substance use disorder, or even 110 or 125, some number short of the full amount. There's nothing in the settlement agreements to date preventing this from occurring, and that's one purpose of establishing a dedicated fund for these monies. And of course, each state needs a baseline level of understanding of what already is spent on SUD in order to track this. And so because of this concern or this issue, what we're seeing around the country is legislation that's being introduced to prevent this from happening. There's a template model legislation which has language in it to address this, as well as other language that states are considering. Temple University has a database of state laws that direct opioid settlement dollars and discusses each state, what their laws and legislation looks like. Opioidsettlementtracker.com is actually a fabulous resource that lists every state's allocation plan, what the legislation is it pending, has it passed, what are the allocations between the state and locals. It's a great resource. So these are just a list of some of the tools and resources that are out there for this. The second set of strategies really are about ensuring accountability and transparency in how decisions are made about the way funds are spent. And these strategies are for any decision-making or advisory board. Ethics codes exist in many states already, as do requirements for certain meetings, which might be outlined in a state's open meetings law or sunshine law. Those existing state ethics codes or any other laws and standards should be reviewed to determine if those requirements apply to the entity making decisions on opioid litigation funding. And potentially updates might be needed to make those laws apply to these bodies if that's the decision. I'll jump to the third bullet, that decision-making meetings should be open to the public, available on the internet, with materials posted. That's a trend that we're seeing many states adopting, to really open up the meetings where these decisions are made so people can understand what's going on. And the second bullet here is about having a diverse makeup of the decision-making or advisory council, board, or committee that is guiding spending. So on this slide, we can see the different types of representation that might be on councils across the country. So that can include law enforcement or criminal justice, elected officials, representatives from government agencies, medical providers or social services providers, public health, and human services, private health and human services, and lived or shared experience. So the top bar here shows the makeup of the council in Hawaii currently: 25% law enforcement or criminal justice, 25% government agency, and 50% health and human services. The bottom bar shows the nationwide average makeup of these councils. And again, this is going to vary state by state. One best practice for ensuring the operation of these councils is transparent and accountable, is to establish a specific conflict of interest policy, which includes a number of things. And we have a brief that we just put out about this if you want to read more about it. But high level, it's a process for recusal when there is a potential conflict of interest, ethics training for the council members, and a mechanism for reporting potential ethical violations and resolving them. Another strategy includes a commitment to public reporting of settlement expenditures. Some states have robust mechanisms in place for that, and others don't or don't yet. And then a third governance practice is to align these new settlement funds with existing initiatives addressing addiction across the whole of government, to really establish a comprehensive vision for addressing substance use in an individual state or county. And really the question here is, where do we want to be in 18 years after this settlement money is spent? These funds are, of course, an incredible opportunity to change the way addiction is addressed in this country, in individual states and individual counties and communities. It's an opportunity for states to evaluate their existing systems and really ask, how much are we spending now? Where are we spending? What are we buying? What outcomes are we measuring? Are we evaluating and adjusting accordingly? Or are we spending maybe plus or minus whatever we spent the year before? And this is a process that might take some time, but some states are starting to consider it, looking at their policies and programs across all government agencies, and ensuring that those really reflect science, evidence, support recovery. And we're talking about all different systems, right? The treatment system, but also healthcare and hospitals, child welfare, the criminal justice system and courts, could be even economic development, right? Addiction does not discriminate in any one of these kind of agency silos that we sometimes find ourselves in. And really, taking a look at policies and programming across all of these to evaluate whether they are rooted in what the research is saying actually works. The second is standardized outcomes for substance use disorder across government agencies. We know that outcomes might vary depending on the agency that's putting out the proposal, or maybe has certain reporting to federal government agencies, and it might really vary across the board. And to look at that and understand what are the kind of core set of values and goals that we as a community, as a state, want, and driving, this is the third piece, driving funding and aligning funding to meet those outcomes. And the fourth piece is about governance, again, identifying somebody who has authority to prioritize a challenging project such as this, and align the goals and align the data. And this report is has a lot more detail, of course, in it, but that's high level what it talks about. And so, of course, there's a real opportunity to use the state budget making process to do this and to align settlement funding with other federal and state dollars for a true cohesive system to address substance use disorder, and have a feedback loop, continuous feedback loop, evaluating whether what we're doing is working. And that can include blending funding, including settlement funds, braiding funding, or doing other types of budgeting mechanisms. So I'm going to touch on a few frameworks that are out there to guide spending, and there's a lot out there. There are a lot of groups that have released the wish list for how the money should be spent, and there are a lot of strategies and good work being done out there, good pilots to learn from. I'm going to just highlight a couple of frameworks that are out there, and that I think kind of capture this best. And of course, we have to start with looking at the settlement language about what's allowed. The quote unquote global settlement, which is about $26 billion of the 54 billion or so that's coming down the pipeline. That's the biggest settlement. Has a list in Exhibit E of all the strategies and uses that are permitted. And it has core strategies and then a list of approved uses. So this is where most states are starting. Most states are starting with the core strategies on this list. One in particular to point out, which is has been a big theme, is a big theme in the settlement agreement and is a big theme of where states are starting to spend, is on medications for opioid use disorder or medication-assisted treatment. This is methadone and buprenorphine in particular. In access, increased access to MOUD is what we'll call it, in general, in a variety of settings like corrections, hospital emergency departments, mobile treatment, which I heard discussed. Research shows that methadone and buprenorphine are the only effective treatment to prevent overdose. And when I saw that research, as someone who's been through these systems, I was actually really surprised. But that is what the research says, that programming that does not include access to these two medications have not been shown to be effective in preventing overdose. And these medications are widely recognized by many, many organizations, from the World Health Organization to the National Sheriff's Association, as the standard of care for opioid use disorder. So that's a major trend that we're seeing of where money is being funneled and spent to increase access to those specific medications. Out of the many lists out there, this one from Johns Hopkins School of Public Health, which leads a broad coalition, a many organization coalition in support of these guidelines, guiding principles, spending money to save lives, which is actually what I already talked about, supplementing rather than supplanting existing funding, using evidence to guide spending. And they're actually, there are a few really fabulous databases about, for governments, about evidence-based practices. One of them is called The Cloud. It's out of the University of Oregon. I should have put that on here. And it has a whole curated list for any government entity that's thinking, we want to do work in XYZ space, in postpartum, in prevention for kids, and wherever it is. It has a lot of a really easy to access list from everything that's out there. Talks about investing in youth prevention, the guiding principles focusing on racial equity, and as we've discussed, developing a fair and transparent process. Johns Hopkins also worked with a number of leaders and experts among tribes to come up with a set of tribal principles, because there are specific settlements just for the tribal nations. And these are culture first, supporting cultural and traditional healing; 2, investing in opportunities in reciprocal learning and partnerships across tribes; 3, healing support for families; 4, sustaining and enhancing services for youth; and 5, creating opportunities for holistic well-being. And there's a lot more information about this on their website. So just to wrap up, certainly operationalizing all of these strategies is very, very challenging. I've been there. I've been a person in government trying to make this happen, these changes happen. It's very hard. Fortunately, there are many resources out there for states to learn about what each other are doing, learn from each other. Resources, for example, developed by the National Governors Association. There are state learning collaboratives that have regular calls for state health departments and others to share challenges and ideas in their closed calls, so people can speak about what's happening. And with a planful process in place, this funding can not only save lives, but help start a shift in our systems to truly meet the needs of people and families struggling with addiction, and realizing the vision that I think we all have that has been made difficult over many years with limited resources and other types of challenges, that this could be seed money for that. So some resources slides. This is a QR code for the materials on our website at Georgetown that include also other projects with tools for governments that can help translate science and evidence into policy. We have a number of model state laws and other materials there, links to some of the materials I mentioned. And of course, remembering that these are real people with real families with hopes and dreams and lives, and recovery is possible. So here's my contact information, and I'm happy to take any questions.
Thank you, Professor Wiseman. I have such deep gratitude for you for joining us and doing this work across states to better inform practices. I want to give this opportunity to my members to ask questions or engage in conversation with Ms. Wiseman. I'd also invite Mr. Valera to come back to the table, because I think there might be some shared conversation we might be able to have. From Representative Garcia from Kapolei.
Thank you, Chair. Thank you, Ms. Wiseman, for your presentation. You mentioned there were a certain settlement funds for tribes. Are there anything that's specific to Native Hawaiians here in Hawaii, being that a large, population of those addicted here are Native Hawaiian?
I would have to look and see who the plaintiffs in those cases are, but I'm happy to do that and get back to you.
Okay, thank you.
Great question, Representative Garcia. Any other questions from members or comments? I have a few questions, and I will be sharing with members, Ms. Wiseman, Professor Wiseman, your report, Transcending MET, Money, Ego, Turf, a Whole Person, Whole Government Approach to Addressing Substance Use Disorder Through Aligned Funding Streams and Coordinated Outcomes. That is a mouthful, but this is a wonderful report that was produced on June 2023. Members, I am happy to report that we're doing a lot of the things here, but we can do more. So I wanted Professor Wiseman, if you could comment, one of the things that really popped out at me was the blending and braiding of funding across systems. The whole government approach is, I think, something that we've been talking about for a long time. In the report, you talk about justice reinvestment initiatives and partnerships with corrections. Can you speak a little bit about how we might be able to do that? Because we do have a collaborative here between our judiciary, prosecutors, law enforcement, to do some of these things, but and address some of these substance use treatment, mental health treatment issues. Can you speak a little bit about how we might be able to do that or what other states are doing with regards to this justice reinvestment initiatives?
Yeah, so thank you for the question. I think I'll answer it in a twofold way. And one is about kind of programmatically what's going on. And the second piece is about systemically, I guess we'll call it. So programmatically, what we're seeing around the country is we have a situation, or have had a situation, in jails and prisons in particular, but also in probation, parole, and courts, where many, many people with a substance use disorder find themselves in that system. And traditionally, it's been quite siloed in many places, from the public health system, even from treatment. And what we're seeing is initiatives with a good amount of federal funding to support them to start to bring those systems together and introduce best practices and evidence-based practices into those kind of settings where that's a place where there could be a targeted response to address substance use disorder. People are there, they're incarcerated, they might be in a time where there's a window of willingness to take a look at, what's been going on in their lives, and to have the criminal justice system or criminal legal system be a place that uses that as an intervention point in a way that the research shows works. So one example, and I know I talked about this in my presentation, is the incorporation of access to methadone and buprenorphine in correctional settings. That's a major initiative that we're seeing across the country for a few reasons. One is we see professionals in these systems recognizing that the same people are cycling in and out and aren't getting the help they need to prevent that cycle from happening. And when these medications in particular are introduced, people just stop going back to jail. We've seen that time and time again in counties, in states that are starting to implement this. So that's one reason. The other reason is guidance from the Department of Justice and a series of litigation cases around the country that have been brought against correctional administrators, jails, counties, states, prisons, etc., that allege violations of the Americans with Disabilities Act for failing to provide these medications and being successful. And the Department of Justice issued guidance saying, yep, this is a violation of the ADA. So we're seeing huge uptick of this. And we're also seeing sheriffs and others start to embrace kind of social determinants and really thinking differently about what happens behind the walls when somebody is incarcerated. We're seeing peer support training happening in jails. We're seeing a lot of really wonderful innovations, and then people just don't come back. The reinvestment, the fiscal part, has to do with the money saved from those systems implementing these strategies, either following the person or moving away from the silo of the system that they're in, right? So that the whole community can work collaboratively to enjoy shared success of people who are moving on with their lives outside of this cycle of being incarcerated, and also the shared savings. It's expensive to incarcerate people, much less expensive when they're not incarcerated and out there working, paying taxes, right? So there are different models out there to operationalize that, but definitely more work to be done and some innovation to be had about that.
There's so much in here, and I'm looking at our time, and I want to be mindful of our time. I'm going to do one more question with you, Shelley, and I want to invite you and your team to come out to Hawaii to provide us with any kind of technical assistance. We, again, have an extremely active collaborative. We have been working with folks like Judge Leifman, I believe, to design a system around corrections, jail diversion, mental health treatment, substance abuse treatment. I think your voice added to our conversations could be helpful. So I have one more question for you, and then a quick question first for John. John, I heard Professor Wiseman talk about federal funding from SAMHSA, possibly from the DOJ. Does ADAD have any SAMHSA grants related to opioid remediation? I believe we had received some grants pre-pandemic. Do we have SAMHSA grants?
Yes, we have. Sorry, Chair. We have SAMHSA discretionary grants called State Opioid Response, or SOAR. We currently have one.
What is the aggregate amount of money for those funds?
I think it's about $4 million.
Annually?
It's a 2-year, so I believe it's $4 million, yes, per year. And it would go to address the methamphetamines and stimulant use disorders, cocaine, I believe, yeah.
Okay, so this is separate and apart from the $156 million that we saw from the AG's monies for the settlement funds.
This is separate, a SAMHSA grant separate from the settlement.
Okay, so I think this notion of braiding and blending funding, we have money in the system that can be used, and we need to use those for
Yes.
these kinds of things. And I think the comments about transparency and accountability are very important, and we've learned a lot that there's different models out there. I would also suggest, and quick question, Mr. Valera, is Department of Law Enforcement Director Tommy Johnson, does he have a seat at the table for the opioid advisory committee?
Currently, no, but we haven't gone to the point where we're issuing out invite letters yet.
Okay.
But yes, definitely.
I understand how the committee may need to be not expand, but certainly in the working groups, tying in and bringing in all of these other areas of state so that we do actually have a whole government approach, I think is really important, and from what we've heard from Professor Wiseman. And my last question, Professor Wiseman, again, so much rich information and solutions in this report. Again, I will be sharing it with my colleagues, but something else really did jump out at me, and I want to put everyone on notice that this is some of the things that we're going to be looking at. You know, in one of your suggestions, there's a comment about the Mental Health Parity and Addiction Equity Act. And this is really, I think, about holding all payers in the system accountable, and maybe helping ensure that people and families who have to navigate difficult insurance claim processes, that they also be provided the help and funding that they might be able to receive from their own private insurance. Can you speak a little bit to that? Because I think this is one area that we have not yet explored, and I don't know that many states have figured out what the levers are to actually ensure parity.
It's a great question. There's a reason why many states have not figured it out. It's very, very complex. It's difficult. It's resource intensive. It's a cross-agency endeavor. We have seen some progress starting on this, and some collaboration also with state attorneys general as well. But I think the best practices we've seen are a combination of things. One is having language in state law, both in the laws that govern how the Medicaid system operates, as well as the laws that govern how the commercial insurance system operates, that codify certain practices, prohibiting certain practices like fail first type of practices by managed care organizations, or excessive utilization management type of practices. So really kind of getting in state law what insurance companies essentially can and can't do to expand access to treatment. There has been a huge initiative across the country and states to remove prior authorization as a permissible tool for insurance on any manner of medications, also for mental health treatment, and up to, I think, up to a month of treatment, things like that. So there's some great resources on this. And then a robust enforcement mechanism in state government that's comprised of the agencies that oversee health, mental health, substance use disorder, as well as the state insurance commission. And I apologize, I'm not familiar with kind of the way the Hawaii agencies are organized, but all of those different entities have to be at the table and doing some robust enforcement. And that is going to take government to be funded to hire FTEs to be out there doing those reviews, doing that investigation. It's a government person intensive project, but at the end of the day, insurance companies are held accountable. Fines can be issued, takebacks can be issued, and it can end up saving the state many millions of dollars potentially, depending on the situation. So again, happy to share more resources on parity. It's a very important and complex issue. I will also say there are, when I worked in New York, we created an ombudsman program for patients who are having denials to be able to have a civil legal services representative assigned to them to help them navigate the appeals process. And from that, we gleaned a lot of data about what those denials were looking like and what those patterns of denials were looking like. So that's another practice that's been very successful.
Thank you. I think you're leading us in the right directions. I think Hawaii wants to continue to be at the forefront. We have a health insurance commissioner who has worked very collaboratively with us on all types of health insurance programs. So this might be the next frontier for us. I certainly would be happy to make sure Hawaii is a leader in this area. Again, thank you so much, members. Any further questions or comments? I'm going to actually allow Mr. Valera, Mr. Hansen, and then Professor Wiseman to make some closing comments if there's no further questions. And then we'll wrap this up right about 11 o'clock a.m. Mr. Valera, you're up first.
So, thank you so much. This has been a very great learning experience. If the professor has any sort of listserv or some kind of learning collaborative that they could recommend to us as a state alcohol drug use agency, I'm definitely would like to learn more. And but yes, we definitely are interested in braiding funds and standing up the settlement project and getting it going. Learned a lot today.
Thank you so much, Mr. Valera, and thank you. This is going to be, I think, the beginning of a conversation for us, but it's certainly very exciting opportunities to collaborate. Mr. Hansen and then Professor Wiseman.
Just want to thank everyone for this opportunity. Shelley, I have that exact same poster here to my right. I can't move my camera, but I feel a connection to you. Thank you so much for all of the information you shared. If you had a guide at how to help state bureaucracy to get out of the way, to make use of these funds in fast and appropriate ways, I would love to see a copy of that, or perhaps you could write one up. I know there's the reality of accountability and transparency and all of that. But when we create obstacles or it's difficult to find ways to get past those obstacles, but it sounds like this committee is committed to seeing that these funds are used quickly and appropriately in order to save lives. And I truly appreciate that. Mahalo. And
Professor Wiseman, you get the last word and then we'll adjourn.
Yes, thank you all again. And of course, that's why we titled the report Money, Ego, and Turf, because that's the trifecta of things not getting done that should. And, my final words is to commend all of you for this work. This is not easy. It's not easy bringing along a system or having innovation in a system where you're also trying to put out fires every minute and moving things in the right direction. It's, it saves lives. And the work that you all are doing every single day is saving lives and helping people not only live, but also thrive. And, if no one told you that today, I will. So thank you.
Thank you, Professor Wiseman. I lied a little bit. We're going to have one more final announcement from myself as chair. Members, our next informational briefing is actually going to build upon this. It's going to be with Dr. James Ireland, Ian Santee, Kathy Higa, and Rachel Rin of City and County of Honolulu to talk to us about what they're doing with their core services, which is addressing in part some of the drug problems that we are seeing on the streets. They're also going to be discussing with us their larger community paramedicine program and what's happening with Honolulu Emergency Services Department. I want to thank all of our presenters today. This was incredibly productive, informational. We will be taking many of these ideas and comments into the next legislative session with us. We can do some things immediately that don't have to wait legislation, and we will certainly continue to provide oversight over all of these important issues. Thank you all for joining us. And again, Professor Wiseman, we would love to see you and your team out here if you ever have the opportunity to come out to Hawaii. And on that note, we will adjourn. Mahalo all. We're adjourned.